Hi, I'm Jane Goodall. This is Charles, who's consented to a knee examination today. He has no underlying pathology and is fit and well. After taking a thorough case history, I'd want to observe Charles's posture and movement patterns. So Charles, if you can bring your feet together for me. I'd be looking for signs of femoral anteversion, the alignment at the knees, such as varus and valgus, any tibial torsion. If you can step apart, please. So then I'd want to further inspect for any signs of pes planus, which could affect tibial torsion, and this may exacerbate any patellofemoral problems. Okay, Charles, could you walk towards me, please, steadily, and then turn around and walk back? So we're looking for smoothness and symmetry of his gait, noting any abnormalities such as antalgia, a waddle, or a broad-based gait. If there's signs of foot drop, we could be thinking a common peroneal nerve palsy or a sciatic nerve palsy. Right, Charles, if you would, going on now to look at your core stability, if you can stand on one leg for me and squat down for me 90 degrees. So we're then looking for any rotation in the knee and the other side as well, any hip drop. That's lovely, and then we'd repeat this on an unstable surface as well. This could identify any issues with his balance and core stability that would affect his knee. Then I want you to walk towards me now on your tiptoes, please, Charles. Great, and turn around and walk on your heels. So this is evaluating around 90% of his neuromotor function. And because he managed that fairly well, that tells me that there's good integrity of his nerves and his muscles. So now I further want to inspect the front and the sides and the backs, looking for swelling, looking for atrophy, fasciculation. In the popliteal fossa here, if there was any swelling there, that could indicate that there was a Baker cyst or a popliteal aneurysm. I'd look at the alignment of his Achilles tendons while I'm here. That's great. And again, we could further inspect for a varus or valgus deformity as well, the knees. Lovely. Charles, would you like to lie on the table for me, please? Thank you. That's great. That's lovely. And then just relax your legs down. Okay, so I then start to palpate around the tensor fascia lata, going into the iliotibial band and where it inserts into the girdus tubercle. Any tenderness?
No.
Great. And we can also feel for tone in the quadriceps and palpate down into the tendon. We could palpate in the inferior pole. Any tenderness there?
No.
That could indicate, there was tenderness, it could indicate a jumper's knee. We're obviously comparing bilaterally, and we will palpate into the tibial tubercles. Any tenderness there?
No.
No, that could, if there was tenderness there, that could indicate an Osgood-Schlatter's disease. Whilst we're here, we can palpate the pes-anserine insertion. Any tenderness there?
No.
Lovely. And also the fibular head. Great. Okay. We can move and palpate the patella under its medial surface. Any tenderness there?
No.
And also the lateral surface. No tenderness?
No.
Great. And the joint lines? Medial and lateral. And again, no tenderness there?
No.
Great. So now I want to test active range of movement. So Charles, as comfortably as you can, as far as you can, you can take your heels towards your bottom. And it should be roughly around 140 degrees of flexion. Started off in extension, so now we're going to go back, straighten out your legs for me into extension. And we can pick up your heels, we can pick up his heels and look for signs of hyperextension. Less than 10% is normal. And I'm going to examine your knee passively. Charles, if you just relax fully for me. So then I'm going to palpate here for any signs of crepitus, tissue approximation, and then any restriction, inequality, and then range, and then tissue stretch into extension. That's lovely. internally and externally rotate the tibia. It's lovely. Okay, and then I'm just going to relax the leg down, and I can do a superior glide, inferior glide of the patella, medial and lateral. Okay, that's lovely. And then if you bend your knee, I would do some resisted isometric testing now of the knee complex. So Charles, I want you to just push your heel towards your bottom again for me. Lovely. And then push your leg out to straighten it. That's great. I'd also test for dorsiflexion as well, because this movement creates movement in the tibiofibular joint and also increases stress there on the supporting ligaments. So just push up into my hand, Charles. Great. And I test plantar flexion as well, since the gastrocnemius crosses the knee joint posteriorly. That's lovely. So once we've done this, I would then look at some special tests, looking first of all for effusion. So major effusion, an acute hemarthrosis, can be caused by patellodislocation. It can be caused by an anterior cruciate ligament or a peripheral meniscal injury or intra-articular fracture as well. So important to look for. So I would just gently milk down the leg and laterally, and then I'm going to tap the patella. And if it was positive, this would ballot as it bumps down against the femur. If that's negative, we'd then go on to do a minor effusion test. So we would sweep and milk down the fluid out of the suprapatellar pouch and laterally. And if it was positive, we would see a bulge within a couple of seconds there. And that could indicate a minor meniscal tear. Okay, so next I would want to test for the cruciate ligaments, and we'd look for the anterior posterior jaw sign. So I'm just going to move your leg, Charles. Just tell me if it's uncomfortable at all. So we're literally anteriorly and posteriorly pushing on the tibia, and if there is significant movement here, that could indicate a lax ligament or even a ligamentous rupture. So anteriorly, anterior cruciate, posterior cruciate. Okay, so to then look for an anterior cruciate ligament, I would do a Lachman's test. So just relax your leg a little bit, Charles, that's great. And I'm going to brace, I'm going to stabilise the femur, and then I'm going to do an AP shear here of the tibia on the femur. And if, again, we'll be looking for significant movement here to indicate a lax ligament or a ruptured anterior cruciate. Okay, the next tests I'm going to perform are in extension for the medial collateral ligament here. So I'm going to put a little bit of a valgus stress through and look for gapping on the medial side. No problems there. And again, I'm going to go and apply varus stress through for the lateral collateral ligaments. Okay, so I'm going to take the knee into a little bit of flexion, and I'm going to do the same manoeuvre as again, looking for any excessive gapping. Healthy ligaments, there should be little to no movement there. Okay, so the next set of tests are to test for a meniscal injury. The first one is the bounce home test that puts a bit of a loop stress through, and I'm going to just drop your leg, Charles, just let it go floppy into extension, and if there was a radial tear, that would exacerbate the pain. The McMurray's test, okay, I'm just going to fully flex, I'm going to externally rotate and put a bit of valgus pressure through, palpating that medial joint line, and if there are any locks, clicks, pops, that would indicate a medial meniscal injury. So the next one, I'm going to just internally rotate, put a bit of varus through it and extend. whilst palpating the lateral joint line. And again, this actually, this manages to catch the entire posterior horn through to the middle of the meniscus, and looking for the same things there. So if we had a really acute patellofemoral injury, we might be thinking extensor mechanism rupture. We could be thinking also patellar dislocation. We could try and produce this, reproduce with the patella, pushing it laterally, and if this is the apprehension test, if that was the case, Charles wouldn't be allowing me to do this right now because it would be very, very painful. Okay, that's lovely. So I would then go on to do a quick neurological screen. Charles, so can you just lift those up a little bit more? So Charles, this is a light touch which would feel like that. I want you to close your eyes and tell me yes if it feels the same as that. So I would be testing
yes,
L1,
yes,
L2,
yes,
L3,
yes, yes,
L4,
yes,
L5,
yes,
S1.
yes, yes.
Lovely. And then to test myotomally, just relax your legs there. I want you to push up against me with your legs, that's it. So flexion, 2, and then extend your knees, please press out, L3, and then push up with your feet. This is L4, tibialis anterior, and then, Charlie, sorry, just relax that, and push up your big toes, L5, and then down with your feet, S1. That's great. So to conclude our examination, I would want to assess both above in the lumbar spine, the hips, and below the ankles and feet. I would want to do a full neurological examination, and I would, if further required, request imaging. But we have completely normal findings. Thank you very much, Charles.
No worries.
Thank you.